Welcome to GI Endoscopy Author Interview Series. I'm Lyndon Hernandez, Associate Editor at GI Endoscopy. And today we have an interesting paper from Dr. Caitlin Murphy, epidemiologist at the University of Texas Southwestern Medical Center. And the title for paper is Adherence to Colorectal Cancer Screening Measured as the Proportion of Time Covered. Welcome, Caitlin.
Thank you.
Would you like to explain to our viewers the rationale and what made you decide to perform this study?
Sure. So when we think about colon cancer, I get excited by all of the progress that we've made over the last several decades. The number of cases has gone down, the number of deaths has gone down, but we still have a lot of improvement to make when it comes to colon cancer screening. And one of the ways that I think we can improve that is by how we measure adherence to colorectal cancer screening. So typically, someone might measure adherence as either a one-time completion of a test. Did they complete a colonoscopy or did they do a FIT kit? And that might ignore all of the other complicated things that have to happen in order to be up to date with colon cancer screening. So we decided to develop a new measure of adherence where we're capturing and including all of the very complicated things involved in being adherent to screening. So not only did you complete the FIT test or did you complete the colonoscopy, but did you come back for your next test? Did you do the FIT test the next year? Did you complete the diagnostic colonoscopy if you had a positive test? And really try to understand a lot of the nuances involved in colorectal cancer screening.
Very good. And what describe to us the database and how you stumbled upon or planned this database analysis. Is this something available or did you prepare for this years back?
Sure. So UT Southwestern is one of the member sites of what's called the PROSPER Consortium, which is a several site study of colorectal cancer screening. So Kaiser Permanente is involved, UT Southwestern, and some other integrated healthcare systems. At UT Southwestern, we're partners with what's called Parkland's Health and Hospital System, which is the safety net system in Dallas County. So it serves a lot of the patients who don't have insurance or are underinsured and lack sort of access to medical care. But the unique thing about Parkland is that it's integrated. So there are 12 primary care clinics across the county of Dallas, but they also receive specialty and subspecialty care, including gastroenterology. So we can really track these patients across their primary care encounters and their specialty and care encounters and see sort of what happens to them in the healthcare system. So that was the data source that we used for this study. And in the total cohort, we have almost 65,000 people who are eligible for colorectal cancer screening. In this particular study, we used just about 18,000 of those 65,000 so that we could follow them over an entire 4-year period.
Very good. And what are your interesting findings? Let's share that with the viewers.
Sure. So I think the first interesting finding is that we were able to use this new measure of adherence where we looked at adherence as the proportion of time that patients were up to date with screening. So we didn't think about did they get screened, did they not, but over a 4-year period, how much of that time were they covered by colorectal cancer screening in a way that might be adherent to guidelines. So I think the first important thing we found is, yes, this is a way that we can measure adherence to colorectal cancer screening. And then the second thing that we found was that the coverage or the amount of time that people were covered, again, this is a safety net system, so patients tend to be uninsured and underinsured, was really low. And we could identify certain coverage gaps where patients might need to be additionally screened. So for example, we found that a common coverage pattern was only 25% of the time period that was covered, which might suggest that they only had one FIT test and they should have completed maybe 4 over the 4-year period, or they were only up to date with screening in a small amount of time relative to when they should have been for the whole study period.
Was there any interesting or any surprises that you or your co-authors encountered?
I think sort of the surprising thing, but also something that we might have expected at the same time, was just how complicated this is to measure. So there are all sorts of things that a patient might consider when we're thinking about adherence to colorectal cancer screening that's driven not only by the type of test that they receive, but the findings from those tests. So for example, a patient undergoing colonoscopy might have to come back anywhere from 1 to 10 years later, depending on what that colonoscopy might find. Someone completing a FIT has to do that sequentially every year to be considered up to date with screening. But someone who has an abnormal FIT would have to go and have a diagnostic colonoscopy. So just understanding the sheer magnitude of the number of possibilities there are to be up to date with colorectal cancer screening, I think is surprising and a little bit overwhelming. And considering that, that patients really weren't up to date with screening in the way that we would hope that they would be.
Right. And what do you think are the barriers to FIT test or colonoscopy after an abnormal FIT? What do you think are some of the barriers you think is going on to explain your findings?
Sure. Well, I think to answer your first question, we found that very few patients did repeat FIT. So they might have done one FIT during the 4-year period when they should have done 4. And I think there are a couple of reasons why that might be happening. The first is that I don't think we have the same kind of communication or culture around colonoscopy or colorectal cancer screening, rather, that it's something you have to do every year if you're doing a FIT test. And patients might instead think, oh, I did one test, I'm done, like they would for colonoscopy. And same with providers, they might not anticipate or expect that this is something that patients have to repeat every year like they would for some other kind of cancer screening. So I think addressing that from a communication perspective is important. Finding systematic ways to deliver FIT kits to patients every year is also important. For the diagnostic colonoscopy problem, where we found a lot of patients who had a positive FIT did not go on to get that diagnostic colonoscopy, our group has done a paper using this same data set where we show that there's a multitude of factors responsible for why that might happen that have to do with the patient, the provider, and the system. So there's not necessarily one factor that explains it all, but there is a lot going on with delays in care, patient beliefs that I need to get a diagnostic colonoscopy or not, scheduling, availability, that all need to be addressed to sort of improve that process as well.
Right. Very good. And it's possible that the patients may not have been or not aware of the results of the FIT test as well.
Yeah, that's definitely a possibility where the healthcare system hasn't communicated with the patient that you have a positive test and you need to follow up. So that's important too.
On a final note, any directions that you might think of in terms of future research on this topic?
Right. Based on some of the work that we've done at UT Southwestern as part of the PROSPER Consortium, Parkland, the safety net system, has now adapted a FIT first strategy. So they are systematically mailing patients FIT kits every year for them to complete at home and mail back to the healthcare system. So we're really excited by this opportunity, not only that patients are getting screened more so than they have before, but we have an additional opportunity to do things like change the messaging of how patients are receiving these FIT kits. So for example, that they understand, I have to do this year, and I've got to do it next year, and the next year, and the next year. And also incorporating some things about diagnostic colonoscopy and using that as a way to improve how adherent patients are to the colorectal cancer screening process.
Well, thank you.
Yeah, thank you.
Thank you very much, Caitlin.